Thank you, Gaurav. I would make it very simple so that it doesn't get into a difficult situation per se. And we all know refractive surgery is one of the most common surgery done world across after the cataract surgery and more predictable than cataract surgery. That is the advantage because it can be almost 97 or a more percentile cases will be within the plus minus 0.25 or zero point 0.5 diopters. So these are the various refractive surgery we have with us. You can have a cornea-based surgeries. Incisional, we know it's not there. You have a lens-based surgery. You have a bioptics. You can combine the procedures to correct the large amount of refractive error. But looking back, the history of refractive surgery per se, especially the laser refractive surgery for cornea, you have all surgeries which has been there in the past. They're still there. That means all these refractive procedures has been quite stable, predictable for patients. Only thing there may be some refinement in thinking, in processing, and application of these new softwares for these patients. Some surgery have been added, but if you look into PRK, surface ablation, and the flap-based surgery are still there. So you know that all these started way back. Radial keratotomy started in the early 90s, and we all know now it's not a good surgery for a cornea. In fact, anything in cornea may not be good for the health of cornea. But lasers have still been sustainable. And in around 1963, we had the keratome available, though not for refractive procedure as such, which today we are doing, but it was actually meant to correct the corneal refractive power. Low keratomeliosis was there in that time. But if you look in 2016 onwards, we have a SMILE, that is a flapless surgery, which has changed the new concept as such. But looking into amount of refractive error correction, that is not changed. It's still true. Many people will restrict to a limited to a low to moderate degree of refractive correction, which is quite acceptable. But looking at the range wise, it's surprising that you can correct up to 13 diopters PRK, 6 diopter of hyperopia, and large cylindrical power can be corrected. I think recently I was debating with one of my fellow, should we correct 5 diopter cylinder on cornea or not? So with understanding, I said, why should you correct a 5 diopter cylinder, which is going to totally compromise the cornea for future also? You have such a nice range of lenses coming, which doesn't disrupt the corneal profile at all. So these are approved range of refractive correction by various procedure in FDA. And we are looking for a suitable candidate for refractive procedure, mainly for a laser refractive procedure for cornea. Age-wise, we all understand anybody who is more than 18 years, especially the girls, they are more eligible before the males. Males, we normally wait for slightly longer time, maybe 19 or 21, maybe cut off. SMILE till date, FDA says 21 years, but we have done surgery for even for 19, 18 years also. And ICL up to 45 years. Now we are doing different type of phakic IOLs for older age group patients also. PRK 18 year plus. So the age has not changed. The important thing is refractive status of patient should be stable. The refractive spherical equilibrium should not change more than 0.5 diopter within a 1 year. And classically looking for a cylindrical application, and the change in axis of cylinder is also very important aspect of making patient unsuitable for these procedures. These are standard things which we all understand, and all these should be considered. Absolute contraindication for laser refractive surgery, as Somresh was talking about, ectatic disorders, where you have a diagnosis of keratoconus, we should not be doing a laser refractive procedure for those patients, not for actual correction of refractive errors. Other important area which I would understand is controversial would be a patient who is autoimmune disorder, patient having a diabetes, any immunocompromised situation. Normally better to avoid corneal procedure because these patients ultimately may have a corneal surface disorders, and that might change the acceptance and results of these procedures. Dry eye is can be treated, most patients, and most patients who are coming for refractive procedure in young age may be using contact lenses, and if you assess them, they would have some mild dry eye. Idea here is to treat the dry eye first, then assess these patients, then do a refractive procedure per se. These are a routine examination we do clinically. Other important investigations are there now to give you access for a entire range of investigations, making patients suitable or unsuitable. When actually we started doing a refractive procedure, we didn't have these instrumentation to pick you the classical cases of subclinical keratoconus, because when we are doing a corneal assessment, it is only to rule out those cases where you have a subclinical features, and that can be picked up by the pentacam parameters. If you have four quad maps, that gives you assessment of anterior, posterior, the pachymetry map, and you can really analyze them. So these are basic cutoffs which is there with the topography or tomography. Anything keratometry more than 48 may not be suitable cases, difference between both eyes more than 2 diopters, K max and K2 difference more than 1 diopter, or some sort of skewing which is more than 21 degrees is a suspect case for a subclinical keratoconus. Inferior superior difference again 1.4 diopters. But classically we are looking for anterior and posterior elevation. So anterior elevation more than 12 microns and posterior more than 17 microns is a suspect cases, and these cases are not suitable. Now, third thing which has come up now is a pachymetry thing, which is also very significant and very important point to be noted in these patients, especially if you have a difference between superior and inferior more than 30 microns, because sometimes we just see the central area, we don't see the peripheral areas. Peripheral areas would be also be assessed very, very carefully in these cases, especially with peripheral thinning happening in some of the cases of pellucidal marginal degeneration. Central keratotomy may be normal, and you might go through with a surgery in these patients. Pachymetry, if you have a normal topography, 470 is cut off for a laser procedure. If you have abnormal topography appearance, 500 should be cut off for these patients also. This is a typical Bellin-Ambrosio enhanced ectasia curve to pick up the early ectasia in these patients and rule out those cases where you can have problems, because sometimes these patients, if you just see the topography, they may look all right, but if you do an enhanced picturization, then you can pick up early keratoconus, especially looking for a pentacam band, which gives you a total analysis of entire parameters, and if it is more, then it is a case not suitable. So if I have to see pentacam, I might see one parameter that is bad, and that gives you an entire profile of the cornea as such. So this is what all the in the bad you can see front elevation, back elevation, pachymetry, everything is included, and that gives a comprehensive analysis of parameters, and that gives you an entire range of application of this tomography. Recently, we have now looking not looking only into corneal profile in terms of tomography or topography, are looking for a biomechanical parameters also. If you combine tomography and biomechanical parameters, you have much more chance to pick up early keratoconus of subclinical keratoconus, and you can delay or you can postpone or you can prevent surgery in these patients. So I'll not go into detail of this, how it is done. So we are looking for biomechanical parameters, TBI and CBI. These are two indices which can be taken into a consideration, and in fact that improves your analysis for a pre-op analysis of these patients. And these parameters are also used for post-op parameters also, where you can do a serial picturization and pick up cases with ectasia happening also. To summarize the procedure, how we go about these with the indices, we had topography as such, then you have TBI and CBI, those are biomechanical indices. So if you have corneal indices like this, so normally you have a band D value from a pentacam, CBI or TBI from your corpus. If these three parameters are normal, you can proceed with any corneal based surgery for these patients. If out of these three, one or two indices are abnormal, then you have to see these patients for next 6 months, observe them if there's a progression of this or not. If there's no progression and your corneal parameters are almost within normal range, you might proceed with a surgery. That too a surgery which doesn't compromise the corneal thickness. So I would rather do a sort of a PRK or a surface ablation of these patients, or you might try a LASIK extra in such cases, or SMILE extra with these patients. As far as extra surgeries are concerned, not very preferred surgery for many centers or individuals. There are few people still do it, but the results are debatable in long-term basis also. If you have abnormal D value, then these are really suspect cases. They'll also have TBI and CBI abnormal also. So these cases may be subclinical keratoconus. They have to be observed for a long time. But if you remain stable for more than 1 year and age is beyond 21 years, then you might consider doing a surface ablation. But if you have frank keratoconus, then you have to look for other ways to correct patient, which Samresh nicely told us that keratoconus cases, contact lens may be the best option where surgery can be avoided. If patient is not really willing for contact lenses, then you can think of other procedure. If the corneal parameters are stable for more than 1 year, people are doing phakic IOLs also to decrease the amount of refractive error. Subsequently, you can do topo-guided surface ablation to decrease the topographic ablation for these patients. These are some cutoff parameters which I think residents can note there. If you're looking for a residual bed thickness, people say more than 280 or 290 is acceptable, but better would be more than 300 should be the cutoff in these cases. So this 300 is going to limit you the amount of refractive error correction, and the corneal thickness parameter will also come into consideration also. Then we are looking for a percentage tissue altered after surface ablation or after a flap related surgeries. It should not be more than 40%. So if you take all these parameters together, then you are looking for the ultimate change, because whenever doing a laser procedure, we are changing the corneal topography parameter also. If the keratometry goes, less than 34, it's not a suitable case. If you're hyperopic, if it goes more than 50, it's not a suitable case for our things. So you may be having a corneal parameter which may accept the amount of refractive error to begin with, but after ablation, if this happens, then it's not suitable because cornea will get deformed so much, your ultimate outcome may not be better. These are the cutoff for our phakic IOLs, and you have heard normally all phakic IOLs are good nowadays because you have a long results we have now in your hand. Complication rates are hardly there. In fact, we now use ICLs for a moderate to low myopia also. So that is the good acceptance for these lenses, especially which are not cases which are not fitting for a laser ablative procedure. So endothelial normally we take 3, but around 2.8 to 4 millimeter may be normal AC depth. White to white less than 13, more than 10.5. Count normally the young patient, no problems the count as such, but rule out lenticular opacity. Sometimes that may be there. And after surgery, if people pick up the lenticular opacity, they might blame the phakic IOL per se. So this is one example of case. So you have a 22-year-old male patient. The refraction is very nice, 4.5, 1.5 still in the both eyes. But looking into a pentacam profile, you can see that, if you see the calculation, the PTA is 41, and though it is 38% other eye, the RSBT is less than 300. So if you just see this calculation of yours, then look your pachymetry map and a topography map carefully. So see here, you have a small island of a posterior elevation, which is seen here, and your pachymetry at that point is less than 490. So these two parameters is a suspect parameter. So you should not be jumping for a surgery for this patient. Maybe you should wait as such. So if you have around 46.5 again in the K max, I'll be little suspicious in this case also. So all parameters should be assessed carefully and make sure you take a right decision for these patients. So this patient will avoid corneal ablative procedure, maybe observe for a stability. If patient is very adamant, might plan for phakic IOL subsequently after 6 months or 1 year. This is another patient where you have some sort of a little difference between the superior inferior steepening here, and we can call it there's a steepening there, but if you see this patient, other areas are absolutely normal. The corneal thickness is normal in the central area. The belly ambulation are normal in this patient. You can see here the band is normal in this patient. So this patient may be okay for surgery. So what should be doing this patient as such? So we did epithelial mapping this patient. Then we realized this patient has an area where you have a steepening, there's an epithelial thickening. So this was a steepening related to just epithelium. So these are a new dimension for us. We are doing now stromal scanning for these patients. Rather than epithelial scanning, we are doing a stromal scanning, and that can rule out many of these pseudo pixelization which can take you in different directions also. So if you have various factors in your hand, so I would say most important is the patient profile. We were recently concluded one study where looking for the psychological aspect of a patient, and we correlated that to a patient's acceptance for a type of refractive procedure, and the outcome wise also. So we have a patient who is 6'5" in two categories, one patient happy, one patient not happy. What is behind that? So this is a result we want to come out very soon, the psychometric analysis of a patient undergoing refractive procedure. Therefore, this is a very important point here. Patient profile, you should discuss the patient carefully and pick up the right procedure as per the patient's, you can say, work profile as such also. These are routine things we have just discussed in your parameters as such. So this is what I'm summarizing again. Patient less than 40 years, myopia less than 14 diopter, hyperopia less than 6, good RSBT, keratometry within the range. You can do any procedure in such case. The problem comes when your PTA is more than 40%. Then in those cases, you might do a phakic IL surface. Why should you damage the cornea as such in these cases? Nowadays, we get a lot of patients who are more than 40, 45 years. And the patient wants the presbyopic correction also. So you can think of a presbyopic solutions on a laser-based correction also. Or you can do various other options, like if patient has a little lenticular opacity, you can do a refractive lens exchange. You have a very nice multifocal lenses available nowadays. Or you do a presbyopic IPCL or a presbyopic ICLs are going to come now in India also. Those can be used for your patients. So this is again the same way to look into a patient mild to high myopia is a good case for any procedure, especially if they have a normal range of a correction profile in these cases. The problem only comes in those cases where your patient is demanding. Like I should not have a flap, I should not have a dryness, and I want a laser treatment. So what should be offered in those cases? Maybe SMILE, maybe a better procedure, or a PRK. Two options are there, where patient has a contact sports or patient wants some sort of a rigidity in the cornea. I just met one faculty daughter after maybe a 10 years gap, and she was adamant she wanted to do a deep sea diving. And that was her demand, that I want a laser correction also, but I have a passion of a deep sea diving. So I did a PRK for her almost 10 years back. And I met her, she has one baby also now. And she had done the deep sea diving across all the oceans of our world. So this is what you should understand the patient's demand and then give up a solution for that particular category. So this is another example of patient. Again, I'll just do one statement on a customized corneal ablation, because this is the new dimension of a refractive correction, because you can correct all the aberrations also apart from the refractive error. Majorly, if you're looking for a topo-guided ablations for like a contour type of corrections, there you need to have a good assessment of patient, good, you can say a topolizer, a pixelization, and have a good refraction for these patients. Then you can actually do it. So this is one image you can see here. These are, you can have 7 images, and if all the images are good, so this is a fit patient for a topo-guided ablation as such. But if your images like this, which images are not matching to each other, may not be a good case for topo-guided ablation as such. So it's not only patient demanding contour type of treatment or topo ablation treatment, it is the actual assessment and actual picking of a good topography of these patients, which will ultimately get into things. Then your refractive, manifest refraction and the topo refraction cylinder should match. If those are matching, you have a very good patient. If they are not matching, especially in axis-wise, then you have a difficulty. Any axis is more than 20-degree difference, the two manifest and topo refraction, may be a difficult case. So this is what we are showing, customized things. If you have pre-op evaluation of a patient with HOA normal range, wavefront optimization is possible for most patients. Almost 95% of the cases, wavefront optimized satisfies us. But if a higher order aberration, you do a wavefront analysis, if HOA is more than 0.4, then you have to treat accordingly for these patients. Okay, good afternoon, and wish you all the best for the journey towards the Mumbai. Okay. I'll also just summarize, because I have to also go, and I think this I have summarized. I'll just come to the last slide. So this is what I'll summarize. You require a very nice pre-op workup for your patients, choosing right patient as per the patient's refractive profile, the corneal profile, aberration profile, and the patient's own psychic, then do your judgment and do a treatment for these patients. And these are our two books which are commonly read by people, and this is the recent book on our current concept in refractive surgery. This is hardly 250-page book and summarizes everything. And those people who want this, they should write an email to me. I'll send the book to them. Thank you for kind listening.